Hello, everybody, and let me start by thanking Virology Education for allowing me to participate in this very interesting Chinese HIV Clinical Forum and to talk about a very important topic such as the review of the lutegravir and Tegravir registrational studies. These are two very important drugs in the HIV armamentarium. These are my financial disclosures, the names of the companies that pay me for giving talks or support me with grants. And I just mentioned that these are two very important drugs, and this slide shows that different guidelines around the world recommend these two drugs as preferred or recommended first-line ART regimens for antiretroviral naive people living with HIV. You can see that either the lutegravir or Tegravir are base regimens are recommended by the most recently updated DX guidelines, by the DHHS guidelines, by the IAS USAC guidelines, and also the WHO guidelines that have a public health approach recommend a dolutegravir-based regimen in antiretroviral naive people living with HIV. So it's very important to review the data that support this recommendation by different guidelines, and we have to go to see the registrational trials. So the lutegravir was approved in 2013, as you can see in the slide, and Tegravir in a fixed dose formulation was approved in 2018. We have a new formulation of the lutegravir that includes only on one nucleoside, 3TC, in a fixed dose combination. It's called Lovato, and that was approved last year. I'm not going to talk about this because this is a completely different topic. It will be nuke-sparing regimens. These are the structures, the chemical structures of Tegravir, dolutegravir, and other integrase inhibitors. And the purpose of the slide is to show you that both dolutegravir and Tegravir first are very different from raltegravir and elvitegravir. Although if you are, even if you are not a chemist, you can see that the structures from raltegravir and elvitegravir first generation integrase inhibitors are very different from this second generation integrase inhibitor, dolutegravir and Tegravir. Although all integrase inhibitors share this metal alkylating core and the halogenated phenyl ring and the side chain is very different from raltegravir and elvitegravir than dolutegravir and Tegravir. It allows to interact much more in a much more perfect way with the integrase enzyme than raltegravir and elvitegravir. And the other important point is that you can see that both the lutegravir and Tegravir are very similar chemical structures. So these are very extremely potent drugs. This is a slide that summarizes proof of concept ART monotherapy studies. These are the studies that prove that the drugs have activity against HIV, and typically these drugs are given as monotherapy over 7 to 14 days, and we can calculate the decrease in viral load in a logarithmic scale. And you can see that the two drugs I'm going to talk about are amongst the most potent drugs in our anti-HIV armamentarium. The lutegravir produced a decrease of almost 2.5 logs, and cabotegravir 2.3 logs. So extremely potent drugs can produce a profound decrease in viral load by themselves in antiretroviral naive participants. And the other characteristic that is extremely important of these drugs is its resilience to resistant development. These are in vitro selection experiments in cell cultures, and here we are comparing first generation integrase inhibitor in blue, elvitegravir, and Tegravir in pink, and the lutegravir in green. And this is the duration in culture days. You see these experiments maintain HIV in cells replicating while they are exposed to decreasing levels of drugs. And you can see clearly the slide so that it takes much longer for the lutegravir and bictegravir to develop, to select a mutation like 263RK than for elbictegravir. Actually, it takes very few days for elbictegravir, and it takes more than 1 month both for dolutegravir and bictegravir. So in vitro, we can say that these drugs have a high genetic barrier to resistance. And when these drugs were selected, well, another experiment that was performed in vitro was to see the resistance profile of bictegravir and dolutegravir versus isolates that have multiple mutations. It's fine print, but the bottom line message is that here we are accumulating mutations that are very deleterious for first generation integrase inhibitors. You have here raltegravir, elbictegravir, dolutegravir, and bictegravir, and you can see here how single mutations that affect profoundly elbictegravir and raltegravir do not affect at all bictegravir and dolutegravir. It's not until you have multiple mutations that you get a shift in the EC90 fold change of dolutegravir and bictegravir. And actually, if you look at all of these isolates and you see those who are really resistant, those who have an increase of more than equal or more than 10 in fold change, there is much more isolates in this category, both for elbictegravir and raltegravir than for bictegravir and dolutegravir. So the take-home message of this slide is that the resistance profile is different, that single mutations is very rare that confer resistance to dolutegravir and bictegravir, and these two drugs have a higher genetic barrier than first generation integrase inhibitors. So this is a good prospect for selecting drugs. So these interesting characteristics that we have seen in vitro have to be proven in registrational trials. So these both drugs have had a very extensive clinical development program. I'm going to focus here in dolutegravir in the clinical trials in naive, and also in important trial in treatment experience and heavily treatment experience. You have here 9 trials. This is a lot of participants, so we have a lot of experience with dolutegravir. And dolutegravir has been compared to first generation integrase inhibitor in the SPRINT2 study. You see here the primary endpoint at 48 weeks. This was dolutegravir versus raltegravir and 2 nucleosides. And you see at 48 weeks, dolutegravir met non-inferiority. And we have for the first time in HIV therapy this magic number that is close to 90% of undetectable people who are detectable viral loads, and prove the non-inferiority of dolutegravir versus raltegravir. And raltegravir is a very safe drug. So I picked this study because we are comparing dolutegravir with a very safe drug and proves non-inferiority. And the other important result of this trial that is going to be a theme in this talk is that not a single patient in the dolutegravir arm selected resistance, nor for integrase inhibitor, nor for nucleoside resistance. With raltegravir, there was a 6% of patients that develop resistance, 6% of the protocol-defined virologic failures that develop resistance to raltegravir, and there were 4 patients that represent 21% of the protocol-defined virologic failures that develop resistance to nucleosides. So no resistance. So the dolutegravir had been compared also with what has been the standard of care during the many years in HIV therapeutics, efavirenz. Many drugs have compared to efavirenz, but very few have matched the efficacy of efavirenz. Dolutegravir showed in the single study compared dolutegravir with abacavir and 3TC in the fixed dose combination versus efavirenz TDF FTC proved superiority actually after 40 weeks of follow-up with exactly the same proportion of patients undetectable, 88% undetectable. Again, not a single patient developed resistance to dolutegravir, where there were several patients that, as expected, with a lower genetic barrier drug regimen with efavirenz developed resistance. So another very important result, dolutegravir superior to efavirenz. Also, dolutegravir was compared with the other family of drugs with, in this case, with darunavir. Darunavir is a highly potent boosted PI. It was done in the Flamingo study, and this study proved superiority of dolutegravir, again, a very high percent undetectable, 90% versus 83% in the darunavir-ritonavir arm. And there was no resistance in either group. That was expected because protease inhibitors had a high genetic barrier for resistance. So another very important study of dolutegravir that is quite pertinent and has had a profound impact on how we rescue patients who fail initial therapy with 2 nucleosides and with 1 non-nucleoside reverse transcriptase inhibitor is the Downing study. In the Downing study that was performed in resource-limited countries, individuals who have failed a first-line regimen with 2 nucleosides and 1 non-nucleoside reverse transcriptase inhibitor were randomized to receive dolutegravir plus 2 recycled nucleosides or lopinavir-ritonavir boosted plus 2 recycled nucleosides. And the DSMB had to stop the trial because dolutegravir treated participants were doing significantly better than lopinavir-ritonavir treated participants. And these results was maintained regardless of baseline viral load or CD4 cell count, or if the doctors followed the WHO recommended second-line nucleoside reverse transcriptase inhibitors, or even if they are the NRTIs were fully active or not. So this study is the basis for the WHO recommendation of using a dolutegravir-based regimen for second-line therapy after failing a first-line therapy, including a non-nucleoside reverse transcriptase inhibitor. And finally, dolutegravir has been studied also in patients with a lot of resistance to integrase inhibitors. When you have resistance to integrase inhibitor, you have to double the dose of dolutegravir. It's 50 milligrams BID. For the other trials that I have mentioned, the dose of dolutegravir is 50 milligrams once a day. But when you have resistance, you have to double the dose and give it twice a day. In the Viking study, these patients who have already integrase resistance, you can see that the activity of dolutegravir double dose was maintained in those who didn't have the 148 HKR mutation. It was 80% efficacy rate at 24 weeks. When this mutation appears with 1 secondary mutation, the efficacy rate decreased. And when you have Q148 plus 2 secondary mutations, the efficacy rate is much lower. This was a very important study to tease out what were the mutations that impact more dolutegravir. So the take-home message is that you can use it if the patients have failed first generation integrase inhibitor, but you shouldn't allow them to fail for very long, because if they accumulate mutations, also have an impact on dolutegravir resistance. So bictegravir has had also a very large development program. We have 2 studies in antiretroviral naive adults, and we have another 2 studies in virologically suppressed adults. We have also studies in adult women and also in pediatric patients. So because we have already dolutegravir being compared with NRTIs within first generation integrase inhibitors and with boosted PI, what dolutegravir did is was compared, bictegravir did was compare itself with dolutegravir. Bictegravir is available as a fixed dose formulation. You cannot have bictegravir alone. So this first study, the study 1490, compared bictegravir, emtricitabine, and tenofovir in a fixed dose combination versus dolutegravir with tenofoviralafinamide and emtricitabine. And the study proved the non-inferiority of bictegravir, but two different statistical analyses. So bictegravir is non-inferior in this study to dolutegravir, and there was no resistance selection in either group. Also, in the study 1489, the fixed dose combination of dolutegravir, abacavir, and 3TC was compared to the fixed dose combination of bictegravir, FTC-TAF, extremely high efficacy rates. Non-inferiority was proven. The two drugs did very well, and no resistance development in either group. So I've presented you the registrational trials of dolutegravir and bictegravir. If you ask the question if there are differences in more difficult to treat patients, here you have all the registrational trials of dolutegravir and bictegravir, and you have here the results broken down by baseline viral load of less than 100,000 or more than 100,000. You can see that the activity of both bictegravir and dolutegravir it's in general maintained in patients with 100,000 copies per ml, and is favorable when it's compared with either darunavir, ritonavir, or is compared with efavirenz. So are potent drugs in patients with high viral load. So summary of the registrational trials of dolutegravir and bictegravir. Dolutegravir plus 2 NRTIs was non-inferior to raltegravir plus 2 NRTIs. Dolutegravir plus abacavir 3TC was superior to efavirenz, FTC, TDF. Dolutegravir plus 2 NRTIs was superior to darunavir boosted with ritonavir plus 2 NRTIs. And both drugs, bictegravir and dolutegravir, when they have been compared head-to-head, have been non-inferior. And again, with this spectacular result of no resistance development to dolutegravir and bictegravir. These are in general safe drugs. Let me give you an example of one of the studies I present to you, the comparison of the fixed dose combination of bictegravir with the fixed dose combination of abacavir. After 3 years of follow-up, not a single patient treated with bictegravir have to stop the study because of adverse effects. These are the recently updated IACS guidelines. What do you have to know about adverse effects of dolutegravir and bictegravir? Both inhibit a tubular transporter of creatinine, so you should expect a small increase in creatinine, but this is not due to renal damage. It's just that they are blocking the tubular excretion of creatinine. So that's if you calculate the GFR, it will go down, but if you calculate real GFR with like cystatin or eoxol, it wouldn't go down. In some patients, you have sleep disturbances. It was described with dolutegravir, and I will talk later. With both, you can have weight increases. In this meta-analysis of Gilead trial, you can see that there was more weight increase in participants who were treated with integrase inhibitors than with PIs or NRTIs. Both bictegravir and dolutegravir produce more weight increase than the bictegravir cobicistat, and also the weight increase was amplified when the nucleoside was tenofoviralafinamide in contrast with abacavir, TDF, or sidobulin. This is an area of active research. You have to know that both the dolutegravir and bictegravir produce an increase in weight higher than other families of drugs, but still we don't know what will be the long-term consequences of this increase. Dolutegravir also had a signal in the SEPAMO study that it was associated with a higher rate of neural tube defects. The good news is the most recently update of the CEPAMO study is that women that took dolutegravir periconception have a very low rate of neural tube defects and is no longer statistically significantly different from the comparator. So this is a drug that the WHO favors to use also in women that wish to become pregnant after having explained them that it's still a small numerical increase in neural tube defects, but is no longer significant. And also we have very recent data that for women who are already pregnant, the combination of TAF, FTC, and dolutegravir in this study, in the IMPACT 2010, is very safe both for the mother and also in terms of birth outcomes. So it's also good news because we knew very little about Tenofoviralafinami during pregnancy. So that's the reason why both dolutegravir is a preferred drug in the IACS guidelines. We still, in the IACS guidelines, we reserve it for women after the 8 weeks of pregnancy when the neural tube is formed. But again, the risk is very small. And in the WHO, for when you have a public health approach, also consider dolutegravir in women that wish to become pregnant. So finally, a word about interactions. You can give dolutegravir with rifampin, but you have to double the dose. You cannot give bictegravir with rifampicin because the bictegravir level goes very down, and you have to separate it from antiacids. Both can increase the levels of dolutegravir, of metformin, sorry, more with dolutegravir than with bictegravir. So it's something important to know, especially with dolutegravir. If your patient is a maximum dose of metformin, you have to decrease it because dolutegravir increases the levels of metformin. And with antacid, you have here in the slide, you have to separate antacids that contain aluminum or magnesium. You have to separate it from the taking both dolutegravir and bictegravir. So in summary, choosing among bictegravir and dolutegravir, the advantages of bictegravir is a fixed dose formulation, once daily with FTC TAF, few drug or food interactions, high barrier to resistance. The disadvantages is only available as an STR, and there is limited safety data in pregnancy. With dolutegravir, we have an STR once daily with 3TC or with abacavir 3TC. Also are available as a single agent, so can be combined with other NRTIs, few drug or food interactions, high barrier to resistance, a preferred option for pregnant women. Doubling the dose can be given with rifampicin, and doubling the dose can be given if prior integrase resistance. Abacavir co-formulation requires HLA 5701 testing, increases metformin levels, and concerns remain, although much less regarding safety and conception during early pregnancy. But as I mentioned, the latest update of the CEPAMO study say that the risk is extremely small. Thank you very much for your attention.